Hi there. My name is Daniel Campioni-Norman and I'm currently in FY2 at St Heliers Hospital, and today we'll be talking about pancreatitis. By the end of this lecture, you should be able to briefly outline the pathophysiology of pancreatitis, identify some common causes, the clinical presentation, and know how to investigate and manage pancreatitis, as well as be aware of some of the complications of pancreatitis. So what actually is pancreatitis? So pancreatitis is a condition characterized by the inflammation of the pancreas. This is usually due to some form of initial insult which causes intrapancreatic activation of the pancreatic enzymes. This is commonly because of duct obstruction secondary to gallstones. This has a toxic effect of bile salts building back up and causing damage within the pancreas, or you can have direct acinar injury. Things like alcohol can alter plasma membranes and also trigger enzyme activation. Once the disease has been initiated and the enzyme activation has been triggered, we see autodigestion and cell destruction within the pancreas. So, let's say we have a 32-year-old man who's come to A&E. His presenting complaint is epigastric pain. At this point, just pause the lecture and jot down some of the differentials for epigastric pain. So given the title of the lecture, I'd hope you'd get pancreatitis. We can also have pathology of the stomach that can cause epigastric pain such as peptic ulcer disease or perforation, gastritis, and hiatus hernia. We can then have biliary pathology such as gallstones, cholecystitis, and cholangitis, and then never forget pneumonia, and particularly of epigastric pain, you can have an inferior myocardial infarction causing that pain. Although certain abdominal pathologies, localised to typical places on the abdomen, do be wary of abdominal pain. If we go back to the embryology, we can divide the abdomen into the foregut, midgut, and hindgut. Foregut takes you from your esophagus to the second part of the duodenum. Midgut is your third part of the duodenum to 2/3 along the transverse colon, and then your hindgut goes all the way along to the upper anal canal. Initially, when you get inflammation in the abdomen, you only get inflammation of the visceral peritoneum. This inflammation localizes to specific regions depending on the embryological origin. So the initial inflammation for anything in the foregut will localize to the epigastric region. Then, when the inflammation spreads and you begin to inflame the parietal peritoneum, so that outer layer of the peritoneum, that's when you can get more localized pain over the specific area where the inflammation is. So you just have to be quite wary of abdominal pain, and even though you may have pain in one area, it could just be that it's early inflammation and that pain is yet to localize to the anatomical area where it is. So if we move on to the history of our gentleman, so with all pain we'll take a Socrates history. So the site is epigastric pain. It was acute onset and the character is severe and sharp. He tells us it radiates to the back and is associated with some vomiting. It came on about 1 hour ago and nothing has made it better at the moment. He tells us his severity 10 out of 10. Socrates gives us a very good history regarding the pain, but we may need to make sure we start asking specific questions to really narrow down our differentials. So first of all, we can ask about the colour of the vomit. If it's coffee ground, we may be thinking of an upper GI bleed. If it's bilious or fecalent, we may be thinking of small bowel obstruction. If the patient has been constipated, again we may be thinking of bowel obstruction, or if they're having diarrhea, we may be thinking of gastroenteritis or some sort of inflammatory process. We can then move on to ask about risk factors for peptic ulcer disease, such as previous NSAID use and H. pylori. Then we can ask about risk factors for pancreatitis, so if the patient has had gallstones before, if they drink excess alcohol, if they take steroids, have had a recent ERCP, and a student favourite if they've had any recent scorpion bites. Then we need to make sure we ask about past surgical history, If a patient has had previous surgery, they're more likely to have adhesions, and this can lead to small bowel obstruction. Finally, have they ever had any CT scans previously? How long ago were they, and did they show anything of interest? So when we ask our gentleman these questions, he drops in that he does drink quite a lot of alcohol, about 30 to 40 units a day. Then we move on to our examination of our patient. So he's got a tender abdomen in the epigastric region, but he's not guarding and his tummy is actually quite soft. His chest is clear and he's tachycardic, but he's not got a fever. So at this point, we probably think it's a diagnosis of pancreatitis. We've got a young gentleman with a history of excess alcohol use and a tender epigastric region on examination of the abdomen. So, now think about what investigations you might want to do next. So pause the video for a moment and just jot down what investigations you might want to do when investigating suspected pancreatitis. So with all investigations, we want to start with our simple bedside investigations. This includes observations, an ECG, and then blood tests. This would include amylase, LDH, calcium, and we also need an ABG. Then we'll move on to imaging. So with any acute onset abdominal pain, we should be getting an erect chest x-ray. This helps us rule out any perforation, which would show us free air under the diaphragm. We may also want to get an ultrasound of the biliary system to rule out gallstones and identify any subsequent pathology. This is simply just to help us identify the cause for the pancreatitis. The Glasgow Score is a score that allows us to assess the severity of pancreatitis. It should be done within the first 48 hours of admission. The constituents of the Glasgow Score make up the acronym pancreas. So first you need the PaO2. This is why in our investigations we needed to do an ABG. Then we look at the age, then neutrophils, calcium, urea, LDH. Again, this is why we need to make sure we do LDH in the investigations, and then albumin. Finally, we need to look at the sugar as well. You'll notice that amylase isn't involved in this scoring system. So why do we actually need to do a Glasgow score? So the Glasgow score you get correlates quite nicely with the mortality and severity of the pancreatitis. So it can give us a good indication of where we may need to manage the patient and if it can be done on the ward, or they may need more intensive monitoring in places such as HDU and ITU. So a score of 3 to 4 roughly equates to mortality of 15%, a score of 5 to 6 is about 40%, and once you get over a score of 7, you're nearing mortality of 100%. This just highlights how severe a disease pancreatitis can be. How do we diagnose pancreatitis? So to diagnose pancreatitis, you need 2 out of the 3 of the following points. Abdominal pain, suggestive of pancreatitis, so this will be tender in the epigastric region. A serum amylase or lipase, at least 3 times the normal level, and then characteristic findings on imaging. Pancreatitis is normally diagnosed solely on those first 2 points on the previous slide, so abdominal pain suggestive of pancreatitis, and a serum amylase or lipase at least 3 times the normal level. We don't often do CTs looking for pancreatitis. The times we'll do it is if we're not sure of the diagnosis, or to identify any complications in patients who are clinically deteriorating once we've identified they have pancreatitis. The management of pancreatitis should initially follow the management of any acute patient and should be approached in an A, B, C, D, E manner. Following this, treatment is generally supportive and you only manage any complications. So initially patients will need good analgesia. Pancreatitis is an incredibly painful condition and often they need a PCA, which is the patient-controlled analgesia. Patients would also receive IV proton pump inhibitor, and where possible we should continue oral feeding. Following this, we need to make sure we're addressing the cause of the pancreatitis. So if the patient was drinking excess alcohol, we need to make sure we prescribe detox medications when they're in hospital. If it was because of gallstones, ideally they need a cholecystectomy within that same admission. And if there's any biliary duct dilation or common bile duct blockage, they may need an ERCP to remove that. As I said previously, when we were talking about mortality, pancreatitis is quite a severe disease and patients can have quite a high mortality with it. So it's important to involve ITU, or at least the ITU outreach nurses, early on in the case. Pancreatitis has several complications, and we can divide these into early complications and late complications. Early complications include pain, acute respiratory distress syndrome, and they can have metabolic complications as well, such as hyperglycemia and hypocalcemia. Complications slightly later on can include pancreatic necrosis and infection. They can develop pseudocysts, and they can also develop pancreatic fistulas. ARDS is one of the earlier complications of pancreatitis that we talked about. It stands for acute respiratory distress syndrome. Sometimes the initial insult of pancreatitis can go on to cause a widespread inflammatory response within the body, which can affect the lungs. This inflammatory response within the lungs causes inflammatory infiltrates and fluid to accumulate in the lung, as well as a reduced production of the surfactant within the lung. This then leads to atelectasis, which is collapse of the alveoli. Because of this collapse, patients can become quite hypoxic and may need ventilatory support, such as CPAP, which is a continuous positive airway pressure. This continuous positive pressure helps splint those airways open and allow for better oxygenation. Pseudocyst is one of the late complications of pancreatitis. A pseudocyst is a collection of peripancreatic fluid, enzymes, and necrotic debris. It's not a true cyst as it has no epithelial lining, but it's surrounded by fibrous and granulation tissue. It usually presents 4 to 6 weeks following the acute episode of pancreatitis, and it can present with epigastric pain and swelling, dyspepsia, vomiting, and fever. Patients may also have a persistently raised amylase. Pseudocysts can go on to become infected, they can hemorrhage, and they can also cause obstruction of the gastrointestinal system and the biliary system. In terms of managing them, generally if they're small and they're less than 6 centimeters, they resolve spontaneously, but you may need to manage any complications. But if they're over 6 centimeters, they may need interventions such as drainage. So now we're at the end of the lecture, so we're just going to do 5 questions, just try and recap what we covered. So if you'd just like to pause the lecture and just take a couple of minutes to jot down some answers for the questions. So question 1 is, where will foregut pain initially localise to? So when we talked about the embryology of the abdomen, we identified that the foregut is the esophagus down to the proximal part of the duodenum. And when you get that initial inflammation of the visceral peritoneum, that tends to localise to the epigastric region. Then we talk about the Glasgow score. So the acronym for that is pancreas. So the first one is PaO2, then age, white blood cells, calcium, renal, which is urea, enzyme, which is LDH, A for albumin, and then last one is S for sugar. The diagnostic criteria for pancreatitis, number 3, so you need 2 of typical pain for pancreatitis, epigastric pain, and amylase or lipase 3 times the upper limit of normal, and then classical imaging findings. Next, we said, when do you need to do a CT scan? So you only do it when there's diagnostic uncertainty, or if a patient's deteriorating and we want to assess any complications. Finally, question number 5, when should we do the laparoscopic cholecystectomy in a patient with gallstone pancreatitis, ideally on that same admission? So that's the end of the lecture. If you have any questions, as always, please feel free to email me, and I hope the lecture was useful. Thank you.